management issues in stroke. So today is the storytelling in neurology, and we know that whatever the technology improves, the history taking is very, very important. Similarly, the storytelling is the storytelling by the patient and the story listening by the clinician, and subsequently the clinician tell the same story to the students and everyone for learning purpose. So it's very, very important to spend time with the patient to elicit a detailed story. And some patients have very interesting story. Story is like telling in a sequence, not with some interruptions or abrupt change in the scenario. So it is like telling in a sequence, and that makes the story interesting. So some other patients who present it in the clinical scenario with the interesting story and with a particular diagnosis is the main theme of this topic. So I'll be talking on an interesting case of demyelination for 10 minutes. And Professor Bond will be talking on an interesting case of epilepsy. And Dr. Arul Chelvan, consultant neurologist at Apollo Hospital, will be talking on an interesting case of headache. And Dr. Magesh, pediatric neurologist, will be talking on an interesting case in pediatric neurology. And all these things for 10 minutes, and we'll have some brief discussion, and we'll finish the meeting in 1 to 1 hour, 15 minutes time. So this is a 17-year-old girl presented 4 years back to me with the history of acute loss of vision on the right side. She was referred from an ophthalmological hospital and for neurological opinion. And there was no history of limb weakness, bladder or bowel disturbance. The only history was acute loss of vision on the right side. So this is a tertiary referral ophthalmological hospital. So they get all patients' neurological opinion to make sure it's not a pure case of optic neuritis. So all the blood investigations were normal. Serum ACE, vitamin B12, D3 were normal. Neuromyelitis optic NMO antibody was positive. Other autoimmune markers were negative. So we see sometimes a spectrum disorder. So it is a routine practice to do the other autoimmune markers which were negative, and to rule out other causes of optic neuritis. One of the common causes of autoimmune disorders. MRI of the orbit and optic nerves and brain showed short segment demyelination in the right optic nerve. So it's very important sometimes to image the optic nerve, so you can see whether the optic nerve showing some plaque inside. Actually, that gives a clue that what kind of optic neuritis we are handling. She had a 5-day course of intravenous methylprednisolone, 1 gram daily for 5 days. She recovered fully and subsequently started on tablet azathioprine, 75 milligram daily with complete blood count and liver function test monitoring. And subsequently, she not come for follow because she was from a quite remote place in north side of India. And I asked her to follow up with the neurologist there at hometown. And she was taking sincerely all the medications. But 6 months before coming to the consultation, that is 3.5 years after the onset of first illness, she stopped azathioprine by herself because she felt that she's fine and why should I take, and she stopped it. And she's not going for any regular follow-up. And developed sudden onset of total loss of vision on the left side a week before the consultation at Chennai. She came to Chennai immediately. There was no perception of light, and finger counting was not possible on the left side. Regular blood investigations were normal. NMO antibody was positive, and other autoimmune markers were negative. MRI of the optic nerves, orbit and brain showed a long segment demyelination on the left optic nerve. This time, instead of the short segment demyelination on the right optic nerve 4 years back, she had a long segment demyelination of the left optic nerve on the left side. She was given 5-day course of intravenous methylprednisolone, and no improvement in the vision was noted. Could you unmute that, Tom? Okay. And this is the MRI of the orbit and optic now, which shows that you can see the left optic now is showing a long segment demyelination of the optic now. Okay. She was given single dose of, because she not responded to IV methylprednisolone. We are very concerned about the visual recovery. So we don't have any other option that we thought the plasma exchange is cumbersome. She need to admit it for 10 days and they don't have any resources and they can't stay here because they're from long distance. So we thought, okay, we'll give a single dose of intravenous rituximab, which is, there are a lot of study on this, and 500 milligram in ICU setting. So 1 ml of IV was given intramuscular, then 125 milligram methylprednisolone intravenous was given as a pre-preparation for 30 minutes. Then 500 milligram of intravenous rituximab as an IV infusion given over 5 to 6 hours time. She recovered significantly in a week time, almost very good recovery in a very short time. Usually it takes some time, but she recovered very well in a very short time, within a week. So she was started again on azathioprine 75 milligram daily as a long-term prophylaxis. She's doing well now, and there are no symptoms in the vision or in the neurological system in the follow-up period actually. So it is important to image the optic nerves in patients with optic neuritis due to neuromyelitis optica. It's very important because we get a clue whether what kind of like spinal cord imaging. Imaging of optic nerves gives a clue that whether you are handling what kind of plaque, small plaque or large plaque. And then this patient has a large plaque in the left optic nerve. It's very interesting phenomenon. I see quite often in this kind of presentation. If there is a long segment demyelination in the optic nerve, rituximab may be a choice in the difficult situation, not routinely. That you have to, if the patient is not responding to steroid, you have to keep in mind, especially in a scenario where you can't do plasma exchange and all those things. So the incidence of neuromyelitis optica spectrum disorders is a monophasic illness in 1 to 2% of patients. That is, if people have monophasic illness, men and women, the incidence is equal. But if they have like a recurrent illness or relapses, the women incidence is quite high actually, almost 10 times more compared to men. One retrospective study, patients found that Asian, Afro-American, Afro-European patients, seropositive for aquaporin 4 antibodies, at a younger mean age of onset and higher prevalence of brain and brainstem involvement than Caucasian patients. So you have to keep in mind there are some pattern of presentation difference between Afro-American and Asian and Afro-European patients. The hallmark feature is acute attacks of bilateral rapidly sequential optic neuritis. So you will get a sequential optic neuritis, bilateral optic neuritis more often, leading to severe visual loss or transverse myelitis with a typically relapsing course. You can be mononeuritis or it can be bilateral optic neuritis, but if you see bilateral at a time optic neuritis, keep in mind it can be a number. So optic neuritis and neuromyelitis optica. So it's a unilateral sequential optic neuritis in rapid succession or bilateral simultaneous optic neuritis. The disease pattern give a clue. Relapsing course in 90% of the patients. Some patients optic neuritis and myelitis occur concurrently. So usually you'll get optic neuritis, there is some gap, or then when you get a next relapse, it can be myelitis. So there are only some patients you get both together actually, not often together. In others, clinical episodes separated by a variable period of time. Patients with cerebral presentations can have recurrent brain attacks without involvement of optic nerves or spinal cord. You don't need optic neuritis to diagnose neuromyelitis optica. If patient has recurrent cerebral presentation, the typical sites in the brainstem and other regions, then they can have recurrent brain attacks without involvement of optic nerves. Some difference of MOG compared to neuromyelitis optica spectrum disorders. So you know that MOG antibody related demyelination disorders, they can have optic neuritis, multiple sclerosis optic. I don't want to go into all because it's quite big spectrum actually, but some important clinical points actually. More likely to involve optic nerve compared to spinal cord. That is the MOG disease. More likely to present with simultaneous optic neuritis. They are more likely to have monophasic or to have few relapses. Less likely associated with the other autoimmune disorders. More brainstem and cerebellar lesions and fewer supratentorial lesions. Spinal cord lesions mainly occur in the lower portion of the spinal cord. If you see upper cervical cord lesion, long segment demyelination, think about NMO. But if you see lower spinal cord lesions, keep in mind it can be MOG disease. So optical coherence tomography gives you can see a greater retinal nerve fiber layer thinning, severe axonal inset. You can do OCT, it gives a clue to you. Microcystic macular edema of the inner nuclear layer appears to be the common among patients with neuromyelitis optica spectrum disorder. So OCT can give some clue that this can be a neuromyelitis optica related optic neuritis. So one report of patients with severe attacks found that initial treatment with IV steroid plus yearly therapeutic plasma exchange was associated with improved outcome. So if you want to do plasma exchange, it has to be done in the early phase. Late phase has a lesser benefit compared to earlier plasma exchange along with IV steroid. So rituximab is a humanized monoclonal antibody that causes B cell depletion by binding to the CD20 antigen of B cell lymphocytes and to FC receptors. Reduction in the annualized relapse rate. There was a small study in Japan with 38 patients, and they also found there is a benefit of rituximab. There is a systematic review of observational studies found that rituximab was associated with a reduced frequency of relapses and reduced neurological disability in patients with NMO spectrum disorder, but noted concerns about safety profile. There is an article published in JAMA in 2016 in November. So there is a systematic review and meta-analysis of 438 patients, 381 female and 56 male. Adverse events in 114 of 438 patients, that is 26%. 10.3% infusion-related adverse event. That's why you have to give this in intensive care setup. 9.1% infection. Anyhow, it is treatable. 4.1% persistent leukopenia. So you have to keep monitoring this patient WBC count over a period of time to make sure they're not going for, especially if you're going for a chronic therapy. And 0.5% posterior reversible encephalopathy. So this is also a reversible encephalopathy. You can see it is not like that JC virus induced problem. It is a people who have this kind of medication, they can develop a condition called posterior reversible encephalopathy, and 1.6% died, and it is not directly due to the drug, and I think it is a overall issues together actually. Thank you very much.